Hello, everyone. My name is Athena Mohebbi. I'm from UCSD, and I have a PhD in nursing. We're going to talk about patient and caregiver education today. How are you doing? More importantly, get involved. That's how I get my patients involved. Say hello. Yeah, come to me. So, because it's been very serious talks, majority of the topics has been covered. But what we do, we constantly talked about protocols. Protocols are like a PhD thesis, it's 200 pages. Somebody, put it together, and this is for patient care. So when they come to us, we read these protocol and we condense them in checkpoints that we can, just like Dara pointed out, because on the day that patients is facing you is like a wedding planning. You plan ahead before the patient gets there. So you will go through these protocols. They're very detail oriented, and you don't want to miss any point of it, because if you do, it's going to be derivation. That's she said, and you miss some points in there. And based on that, not only that, the patient is not going to receive the full care that they came to receive. And the research part also is missing the point that they want to collect the data they're there to collect and help the future of these patients. On the day that the patient come to see me, usually they already have gone through the visit with their physicians. The oncologist, either from out of state or in a state, they send them to us. They visit with their specific oncologist that they call them primary investigator, and they're the one that they introduce them to our team, which is cell and regenerative medicine. We're the one we take care of the patient, inpatient, outpatients in the hospital. On the day that they visit us, we call it a baseline visit, and these protocols do come with the schedule of events, we call them, which it gives you the time from the time that they prepare the cell and all the preliminary visits has been done, all the labs and EKGs, and at that point, they already signed a consent with their physicians before they come to see me. Because they were meeting the criteria. Things changes, as you saw on the pictures earlier with the glioblastoma or some of the other patients that they come with disease of the liver, they may fall off the inclusion criteria by that point. So this visit is important. Not only that, they're already dealing with cancers and they're stressed. They're coming from out of state. I get to know them, and I will help them out to figure out at this point on, before they get to the hospital, what do we need? Do I need a social worker involved? Do I need the housing that we need to help them out? Let alone, we will discuss with the patient. I would introduce my team that they know, okay, who is going to see me in the hospital and what am I expecting when I go to the hospital. At this point, the thorough examination is going to be done, including the neuro exam. And I tell them, this is your baseline. You and I, we are a team in this. So we're going to compare you to you. I'm not comparing you to another patient. I want to know what is today, and if changes tomorrow, you will communicate with me. And they will learn over a period of time, and they will communicate better. That's how we hold each other's hand, to because I'm not feeling what they're feeling. Based on laboratory values, I will show you, you can't guess. And at that point, when everything is looking good, we have a caregiver. Caregiver is very important. So one patient actually had to opt out because they didn't have a proper caregiver, which was sad, but we will find other avenues to help them out. But that was the case. They go through the lymphodepletion, lymphotherapy, chemotherapy that you heard. We will let the hospital know that this patient is already consented and ready to go, and we will place the inpatient request. So the day of the patient is going to arrive. We will discuss it with the patient that, okay, you don't have to come early in the hospital. We will call you as long as you're close by, about like 30 minutes to 1 hour. We will call you when the room is ready, and then you will arrive to the hospital. So the bed is ready, and we will have them bring things to make them comfortable during the hospital stay. remember, this is after the chemotherapy. And sometimes, when they come at that baseline visit, I would recognize if this patient is going to be able to tolerate chemotherapy outpatient or inpatient. But this patient was able to receive the chemotherapy outpatients. Now they're here. So from then on, their cells are low, meaning that they're at the risk of getting infections. They're at risk of having other complications that we need to know. We pay attention. So at this time, these patients are coming from other states or even in the city. We want to save their times and hospitalizations and the cost that they're putting themselves and their family through. So if something is not meeting their criteria, at that point, it's better to save the patients outpatients and before the lymphodepletion. They have COVID tests before they come, and all of the EKGs and labs are going to be done in our hospital on the day of arrival. Majority of the tests are done already. That day is just to hold the bed for the day that they're going to receive the cells. So, and then we're going to go through the process. But these checklists that I was referring to and Dara was referring to are very helpful because it's like why do we have ABCs for the going through the when the patient is coding? Because nobody remembers at that time is stressful, so you may miss a point, or that's why those checklists is going to organize you, that you remember what needs to be done. And even we went one step further because we even do the orders. We create the order sets on Epic, and we call them preference list. We put all the orders already in there, and on the day of arrival, it's easily chosen. And when I go through that, I checklist, I compare it to the protocol one more time. I compare it to the checklist to make sure nothing is missed or nothing in between has changed that I need to add it. We will discuss it with the pharmacy. We would notify them that the patient is here, and in case there is a medication that needs prior authorization, we don't want the patient end up having an expensive medication at that point. The cells are, on the day of the cells, we would discuss it with the patient. We would prepare them mentally that they know that this is going to be a lot of commotions around the bed. It's not that you have an emergency or you're coding at that time. Know that, we're just preparing ourselves in case if you have reactions. You can receive them in blood and have reactions. So these cells are not, we're not discriminating them. So we're going to have you, we prepared, we will even have our rapid response team know that at this time we're going to deliver cells to have them ready. We will do prelim exams again with the ICE score and ICAM because we want to know if this is their baseline. Like one of the presenters said, patients was unable to write. So we compare them to themselves at that level. We know that they're not losing something at that exam. They can have the breakfast, but we're gonna not feeding them till later after the cells, maybe 2 hours later. So there are series of labs can be done. Our labs gets done at 5 a.m. We will go through that. The doctors, also my medical director will go through that. And then we will sign the APPs are the one that do the exams, and we will go through the case together with the physicians, and they're the one they sign the orders at that point. So the cells are going to be delivered, and all the per the schedule, whatever the schedule is, if it's triplet EKGs needs to be done, labs before and after, or every 30 minutes after, we will continue that. I usually encourage patients, even from the baseline to this level, to even with their caretaker, to write everything down and have questions, because the moment we leave the room, we will remember a lot of questions. Toxicities, all of my colleagues, they've gone through it. I'm not gonna go through them again, but just to be a reminder, what's important about the toxicities is the timing. They're not gonna be red flagged or neon sign. They are sometimes very sneaky. They come upon the patient. Patients may not even know. And if you are taking care of one of your healthcare professionals, like nurses, are notorious for not, they have headaches, or they have blurred vision, or they have tremors that they don't even report it. They feel like, oh, it's going to go away. These are the ones that I keep repeating to my patients, that no matter what, please communicate, because we need to know. So the more we talk with them, they're more cooperative. So the toxicities, like hepatotoxicities, one of the things, I didn't hear today was like our immune system works like a messengers. And how do we communicate is like the IL-6 and IL-1 and IL-2s are the messengers. And, the same fact that the body gets out of control, it becomes rheumatoid arthritis, or it becomes lupus, these are the autoimmune diseases that our immune systems should take care of our body and get rid of the bad guys, like cancers. But at this point, the body got used to the cancer. Cancer had become like a pet in the family, and they don't attack it anymore. So we will bring them out, and these chimeric CAR T cells are reintroduced to the body, because now they are retrained to go after the cancer cells. So sometimes they may turn against the body, and that we don't know till we'll see how the body is going to react. So we will keep reminding the patients these, and we have them to let us know. Any medications you take, you have nausea, vomiting, diarrhea, but if there is a cancer in the abdomen region and we send a CAR T after it, they may cause bleeding, and the GI bleeding may be serious. So all of these laboratory values that we check constantly is important. I remember we used to check the T3, T4, and TSH, and I was wondering, why are we checking for stomach cancer? Are we checking these? Because of these CAR Ts, they may affect the endocrine system. Hypothyroidism is very obvious. So the skin rashes and arthralgia, as pretty much what you see in rheumatoid arthritis, you see here. Neurological, with my experiences with these patients, I haven't seen a very serious neurological toxicities, but however, there are some of them, it can be as simple as unconsolable crying. We had a patient that it was outpatient treated, went to the cancer center to receive fluid, and suddenly they were calling that she's crying and we cannot ever, calm her down. And the other patient was telling me that she was picking off the floor items that, these are as simple as these, the toxicities that you may see. And the more and the faster you talk to people and they learn about it, it's better that they let you know, and then you bring the patient back. They're not all very easy to know. So the patient had received their therapy treatment, they're ready to go home, they haven't had any sign and symptoms. So we will encourage the family and the caregiver that they were designated to go home. We want to have the home be dusted, clean, and out of litter. And then also we want to have meals are prepared and ready to go for the patients, because patients is not going to be able to go home and cook for themselves. They're not going to be able to, if their platelets is down, we don't want them even to use, we want them to use electric razor, not even regular razor, because they're going to cut themselves and they're going to bleed. They are more prone to get infections. So we don't want them to have fresh fruits, fresh vegetables. No gardening is allowed. If there is a pet care is not allowed, because they cannot pick up after their pet. Usually the first until their cells gets up, it depends on the institutions. Our institutions, we say above the ANC, absolute neutrophil count above 1,000. Here it seems is 500. It depends, but we want to make sure that they're not getting another infections. So that's important. Family, they can bring gifts for them. They can have deck of card pictures or tapes, but fresh flowers, fresh even dried flowers with moss is not allowed. So that's important. The first place that we have infections in is mouth. Good mouth care, clean mouth, and it's important. Showering daily during the neutrophil counts are low, and changing the clothing is important. They can bring comfortable clothing to the hospital. We would encourage them to, if they want to bring their favorite pillows or blankets, it's fine, but as long as it's not going to be mixed with the hospital items and get home. And then if someone is sick, we learned that during COVID time, that if someone is sick, not to come visit them. If they're having received the live vaccines like MMR or chickenpox, don't come visit the patients that the neutrophil counts is down. As far as sex, if their platelets is below 50, they may have bleeding involved or infections as their cells is low. And then during some of these CAR T treatment, they need to know that they can't. Pregnancy is not allowed, and they may fall out of the inclusion. And so they need to be prepared. Don't go bungee jumping while your platelets is down, and don't get involved with the sports that it may cause injury, like electric bikes. And at the time of discharge, so we send the family home, they clean the house, they have a meal prepared, everything is ready for the patient to go home. So we go through the medication list, whatever they is missed or there's new to them, we have the nurse go through those lists again with them. We go with the wallet card, whatever is not, and if there is ophthalmology visits needs to be done. And the most important part is if during the weekend, who to call, time and where to find us, which hospital. We would usually recommend the patients to reside close, approximately about 40 miles or 1 hour away from the hospital. If they are living close by, it's fine. But if they're coming from another states, here, City of Hope, they have a hotel nearby. We have a La Jolla housing for our patients. So that's very important for the patients. Sometimes they use other facilities to stay close by. So I'm going to go through these cases. There are two similar cases. They received the same protocol. And the reason I bring this up, I've been with the cell and regenerative medicine for about 3 years. And we have had so many patients that they never had toxicities to the level that they need to receive all these 3 medications. So that's why I bring them forward. And there is a difference on the baseline. We don't pick and choose these patients. One happened to be extremely healthy, triathlon, 60-year-old, came from out of state. Family was very supportive, and he was able to stay nearby in one of the closed housing that it was walking distance to the hospital. He was very well educated. It was easy to communicate with him. He already was on board with this protocol. He signed a consent, went through the lymphodepletion, which is, as they previously mentioned, is cyclophosphamide and fludarabine for 3 days. And in our centers, usually they go through that from Thursday through Saturday. They have 2 days off, which is the days that we get them to come to the hospital. He was admitted on the Monday, and he was with us through this particular protocol was very meticulously mentioning that the patient must remain in the hospital for 14 days. So he was in the hospital, was going out of his mind because all the laboratory values were normal. We kept asking him the same questions. He was really bored, and he was using the YouTube video, running 5 miles in space because it was during COVID time. He couldn't leave his room. He had neutropenia at that time, but all those cells were coming back. He was not neutropenic anymore, and he was ready to be discharged. All of the labs and preliminary testing were done. He was this particular protocol would ask to do the eye examination before a patient go home. They had a dilated eye exam, went home, and the next day he was supposed to come see us in the clinic. On the day 15, when he showed up in the clinic, now he said he had a headache all night. And we asked him that, why didn't you call us? He said, well, because I was tired of being in a hospital. I didn't want to come back. And besides, I thought the headache is going to go away. But the headache did not respond to Tylenol. Now he has blurred vision. And he thought that my eye was dilated. So my blurred vision should go away, but it didn't go in the morning. Now we were checking his exams, even though his ICANS and ICE were within perfect score. However, his liver function test was elevated to the roof. So we started it, originally communicated with the primary investigator, and we also communicated with the medical monitor. We treated him with anakinra. And with the first 2 doses, the liver enzymes were not coming down, and we got him through ophthalmology. We checked his CT scan of his orbital exam, and also his head. Everything was normal. We checked for all the infectious diseases that it could have been affected, like a CMV or EBV, anything that could have affected the liver enzymes. None. We switched his medications from diflucan to micafungin, thinking like maybe that is the cause. That was not the cause. So at this time, we introduced tocilizumab. After the 2 doses of the tocilizumab, we were communicating further. We checked his IL-6. IL-6, it doesn't come immediately. I don't know how City of Hope is. It takes about a good chunk of 3-4 days in order to receive the results. So it's not an immediate answer, but his IL-6 from 17 went up to almost 95.5. So it was elevated. Tocilizumab was able to take care of that. However, his symptoms were not improving, and his liver function tests were not going down. So we went and treated him with dexamethasone, originally IV 10 milligram every 6 hours, and then after that we switched him to the oral dexamethasone, and he was able to go home. So with him, within 3 days from that point, immediately he responded to the dexamethasone, and he was able to go home. The coping mechanism, some of the questions that we had about hospitalization, and during hospitalization, the coping mechanism, as I mentioned, he was running in a spot and using the YouTube, or he was communicating and talking to the staff. And he was actually very thankful for his staff to stop by extra time to spend time to talk to him. Just imagine, we go through our tasks, but sometimes we forget that these patients are here for a very, very long time, and sometimes they don't have enough people to come visit them, and especially during COVID time. And the next case is the same protocol that it was mainly was used for metastatic castrated resistant prostate cancer. However, the baseline, this gentleman was not as healthy as the other gentleman. So he had hypertension, type 2 diabetes, and pulmonary embolism and hyperlipidemia. So, but he was able to receive the medication, the lymphodepletion, also outpatient. Luckily, this time it was not during COVID time, and he was able to, he didn't have all the restrictions that we had with the other gentleman. However, this protocol still was advising for 14 days in the hospital. He was really bored out of his mind, and I realized soon within our conversations that he's withholding information, which was raising my anxiety, thinking like, I need his information to come, that I know I cannot only rely on these laboratory values, that if he has any other symptoms. As I said, these are not neon sign for these toxicities. The patients, they need to really know that I need that communication to tell me these particular changes happening. So he was withholding information behind, and then by day 10, he told me that his big toe on the right foot is inflamed. So when we went through that, we brought the rheumatology team involved, and they said, they found out that he had gout, and he forgot to tell us. And interestingly, this patient was working in healthcare. So I assumed that, I cannot assume, I'm imagining that he did not share, or maybe he forgot. Sometimes we forget that maybe if we had something 10 years ago, maybe it's gone. So we were treating him with colchicine originally, but his liver function tests start going down and going up. And in the same day, he was telling me that he has bilateral Achilles tendonitis. He had pain and he was unable to walk. So we were at that time he was on fluoroquinolone, levaquin for his lymphodepletion and for neutropenia. So we switched that to the to cephalosporin, and we moved thinking like, okay, that's gonna help. The tendonitis improved to some degree, but not completely gone. And we had to switch because his liver function tests were going up. We switched from colchicine to the allopurinol, and yet now he had blurred vision. But interestingly, it was even though it was the same protocol and the same CAR-T, in his case, however, the other gentleman, the ophthalmology couldn't find any reasoning behind the blurred vision. All of the results were negative. In his case, they found out that he has increased intraocular pressure, that they were treating him with the eye drops. And his case was getting a little more serious because I was talking to medical monitor at that point every single day, and the primary investigator there was involved. Even though after we jumped on this much faster, we gave him, we knew anakinra did not improve the other case, so we went straight forward to the tocilizumab. However, in his case, even though the CRP was coming down and the liver functions were improving, but the ferritin was the tricky one, and it was keep rising up. And with that was the case that even though we put him on dexamethasone, he was already receiving tocilizumab, he was receiving the dexamethasone, yet ferritin was not budging and kept going up. And at that time was the case that we had to use the rimeticid, which is a switch off. That point, all the CAR-Ts that we introduced to him, it has to stop working. It's like done. So, which is sad because he came and went through all of this process to receive the care. However, technically, we were saying that for the sake of saving the cells, save the patient. We cannot sacrifice the patient for the saving the cells. So the challenges in this case was the fact more challenging for the staff rather than I think for the patients. So technically it was tough. It's always tough for the patients no matter what, but for a staff it was also overwhelming to some degree because we were worried that is he going to share with us everything? Is he going to tell us communicating with us? Because especially when you're in healthcare, you're resistant to certain degree of communications and you feel like I already know this, why are you telling me? And this communication, we had to have a conference call or like a huddle before we enter his room because we all had to be on the same page. We could not have any discrepancy in our conversations, and also our medical director was with us. It was, you know, giving us it was putting us on a pedestal. Every time it would turn around and said, let me see what my APP says. And that helps because it brings it opens up the door that these people I'm trusting. So I want you to trust them too, to communicate with them. With that, thank you very much for listening to me. Thank you. Thank for CERM to let us have this opportunity to talk here, and also City of Hope. I'm very thankful for this time and opportunity and listening. Thank you all.